when we were doing last class, we were talking about the different ways that we classify our joints. And we do it two ways. Okay, the first way is through anatomy, okay, the structural form of the joint, and then the second one is the functional way, which is the physiology. Okay, so I mentioned that the structure plays a huge role in the joint's functioning. So depending on how the joint looks, how it's configured, will determine, all right, how little or how much motion, range of motion occurs at that joint. And a lot of it just has to do with, perfect example is the suture joints. Okay, not a lot of movement occurs there. Okay, because of the actual structural anatomy. All right, you have these zipper interlocking pieces of the tissue, the bone there, that's connected by dense regular connective tissue. Compare that to what we call a diarthrosis, all right, which is our shoulder joint, the glenohumeral joint. Okay, that's freely movable. Okay, so keep all that in mind as you're going through this. That structure is going to play a huge role, right, in how these joints are how they move. Okay, so one of the joints that we were talking about are the synovial joints. Right, these guys here are going to be the most numerous, the most popular. Well, I shouldn't say popular joint, not like it's a popularity contest, but you'll see them scattered throughout the body. Okay, and we classify them as a diarthrosis joint. That means it's a freely movable joint. Okay, so all these synovial joints have some common characteristics that you have to know. Okay, one is they're a capsular joint. There's a capsule that goes around the articulations of the bone. Okay, and because there's a capsule there, then that creates a joint cavity, and inside that joint cavity we have a fluid. Okay, so think of your knuckles. Perfect example of the synovial fluid joint. When you pop your knuckles, you're actually creating a physical state change of nitrogen gas, and that's that popping noise that you hear. All right, it's not bones grinding, but but that nitrogen is dissolved into your synovial fluid, all right, which is in the joint cavity. Along with that, remember, on our long bones, at the ends of the bones, you will have articular cartilage, okay, which is what kind of cartilage? Out of the three cartilage types, what's articular cartilage? What's the most numerous type of cartilage in your body? The hyaline cartilage. Hyaline cartilage. So articular cartilage is just what we call hyaline cartilage on your long bones. Okay? In addition to all that, we also have our ligaments, which hold the bones together. All right? And of course, we're going to have nerves and blood vessels there. Okay? So these are all common characteristics or basic features of a synovial joint. So when you look at the picture here, all right, zoom in a little bit, you can see here we have two bones articulating. We've got our articular cartilage here on the ends of either long bone, okay? Then we've got a capsule that surrounds this joint here, okay? There's different parts to the capsule, very similar to like periosteum, all right, two layers. The outer layer was the rough and tumble layer, you know, made up of that dense irregular connective tissue for the periosteum. Well, we have a fibrous layer here, and then we have an inner layer, all right, which is made up of what we call the synovial membrane. And the synovial membrane is what produces the synovial fluid. Okay, so that will also, so we lump all of that into what we call the articular capsule, excuse me. And then in addition to that, to add stability to the joint, we're going to see ligaments that are going to be around the joint somewhere. Okay, they can crisscross the joint, all right, they can go all the way around, all right, but we'll have ligaments all over the place. All right, in addition to that, then we'll also have our nerves, okay, mainly sensory nerves, okay, because the sensory nerves are there for your body's proprioception or spatial awareness. We'll talk about that more so in chapter 16, but, well, and in chapter 14, but it also will monitor the amount of stretch that goes on in a joint. If the joint is getting stretched too much, all right, we'll invoke the stretch reflex to prevent damage. Really cool, we'll talk about that. And then also you got blood vessels, okay, because we have to supply nutrients to all these structures in here, okay? So now what we're going to do is we're going to take apart all these different components here, and we're going to address them one by one. The first one is the articular capsule, okay? So there's two layers to it, very similar to our periosteum, our perichondrium, two layers. All right, the outer fibrous layer is made up of dense connective tissue. Okay, this is going to be the part of that capsule that is going to add integrity and strength to it, prevents the joint from being pulled apart. Okay, on the inside of that is our synovial membrane. All right, synovial membrane is very thin. It's made up of a loose connective tissue, this areolar connective tissue. Okay, and it lines the entire inside of the joint capsule except the articular cartilage. Why do you think that is? Why doesn't it line the articular cartilage? What do you think? Let me show you the picture. Look at the articular cartilage here. Okay? Pardon? Well, yeah, but if we had that synovial membrane in there, you'd pinch it. You would damage it. It would get smushed and caught, would be bad. So it doesn't make any sense. All right? So we're not going to line the areas where the bones will actually articulate one another. It makes sense, you know, with that synovial membrane, all right? Because we'd be damaging it all the time and we'd have to be repairing it. Okay? So we're not going to see, all right, the synovial membrane anywhere close to where the articular cartilage is lining, right? But its job is to make synovial fluid. Now we're going to talk about the functions of synovial fluid here in a moment, okay? But keep that in mind. Okay, synovial fluid is going to be produced by the synovial membrane here, all right? So the next component of our joint is our articular cartilage, specifically the hyaline cartilage. And you're already familiar with what it's going to do, all right? One, it acts as a shock absorber, okay? Two, it helps to reduce the friction between the articulating bones, all right? And so also, when it offers that reduction in friction, it helps to protect the ends of the long bone. Ask anybody that's been diagnosed with degenerative joint disease. Like that, you hear people say, I don't have any cartilage in my knee, you know, an older person. Well, they'll tell you how uncomfortable that is when literally the ends of their long bones are rubbing and scraping against one another. It causes damage. So the nice thing is, hyaline cartilage helps take care of that. It protects those long bones from getting damaged, all right? Now, when we were learning tissues, all right, when we were learning a lot of things, I always said that there's an exception to some of the rules, all right? When we were learning about cartilage, all right, there's three types of cartilage: hyaline cartilage, fibrocartilage, and then the elastic cartilage. Well, fibrocartilage is the only cartilage that we had learned up until that point that didn't have a perichondrium. Well, guess what? Articular cartilage does not have perichondrium either, okay? Hyaline cartilage does, and this is a type of hyaline cartilage, but articular cartilage does not. So make a point that you know that, and most importantly, because I've seen this asked on test questions too, that articular cartilage, mainly mature articular hyaline cartilage, is avascular, okay? Mature cartilage is avascular. Okay. So moving on, all right, going into our joint cavity now, all right? So this is going to be underneath our joint capsule. And so the whole joint cavity is going to be covered with synovial fluid. So what exactly is synovial fluid? All right, it's going to be viscous like motor oil. All right, it's not going to be as I don't want to say watery as water, but it's not going to be as what's the word I want to use? Well, less viscous. All right, you want to think of it as something. If you've ever popped a blister and that transudate that comes out of there, it's rich in proteins, but it's going to be something similar. The best way I can describe it is motor oil, if you've ever seen motor oil. All right, so its job, all right, is to act as a shock absorber. All right, it too reduces the friction, all right, and provides a lubricating material over those articular cartilage ends. But most importantly is it's going to nourish and remove any of the waste there for those chondrocytes in that cartilage. Okay, so keep in mind, all right, helps to lubricate, decrease friction, nourishes and removes waste for the cartilage chondrocytes, and acts as a shock absorber. Those are the functions of synovial fluid. Don't be surprised to see that again. Okay? Seen that asked on tests many, many times. All right. Now, remember what we talked about way back when we were doing tissues. Okay? You have a tissue that connects bone to bone. We refer to those as ligaments. And I'm sure everybody in this room and everybody at home watching knows that a ligament is made of dense, regular connective tissue. Dense, regular connective tissue, as is a tendon. Okay? So we already know what their role is. They're going to connect bones to one another. And because it's made of that dense, regular connective tissue, it is going to make sure that there is stability to that joint and that it helps to strengthen that joint. The capsule helps with that too, all right? But the ligaments will also reinforce that, okay? So there's two types of ligaments that we see. We've got our extrinsic and our intrinsic, all right? The extrinsic are going to be doing the heavy lifting for joint stability, okay? So they're going to actually separate, all right, physically separate, all right, from that joint capsule. They won't be a part of that joint capsule. So if you were to dissect that joint and you're getting into that joint capsule area, you would be able to differentiate an actual ligament from the joint capsule, and that would be referred to as an extrinsic ligament, all right? The intrinsic ligament, okay, these are going to become part of the articular capsule, all right? So they kind of almost fuse within the joint capsule. We see in the knee, okay, with the iliotibial band, right? But what we'll see is that these ligaments, now if you were to dissect a joint out, it would be a little bit harder to discern an intrinsic ligament from the articular capsule itself, okay? All right, and then well, actually, I always say that on this slide, the last part. But two of my favorite components to the synovial capsule are the sensory nerves and the blood vessels, all right? The sensory nerves, all right, are just that. They're going to be sensory motivated nerves, meaning, all right, they are going to pick up sensations such as what we call mechanoreception, all right, or proprioception, which is your body's spatial awareness, all right? So if I were to close my eyes and one of you was to come over and to lift my arm away from my body, all right, I'm not seeing that, but all the nerves around the joints and the tendons in my upper extremity would tell me what you're doing, all right? That's called proprioception, all right? That's what these sensory nerves will do. Obviously, they're going to report any painful stimuli, right? Because if you start to stretch out a joint and you start to tear things, you need to know that, all right? So one of the ways that you're able to prevent that from happening through what we'll call the stretch reflex, we'll review that later on in chapter 14 or 15, I can't remember now, one of those chapters when we get to the nervous system, all right? But it's a mechanism to prevent you from damaging the tissue. And when you do damage the tissue, you've got those free nerve endings, those what we call nociceptors, and they inform your brain that you're undergoing pain for some reason. All right? Tendons, again, another dense, regular connective tissue, and that's going to attach the muscle to the bone. Okay? And what a lot of people don't realize, unless you're going, is anyone here going into physical therapy? No? Okay. Well, one of the things that you would learn, that the tendons themselves will actually, you are? Okay, good. Well, then you'll appreciate this then, y'all. All right. Well, here's the thing. The tendons, obviously, that attach the muscle to the bone will help to stabilize the joint. And I'll tell you this, I had a patient who's a football player, and he tore his ACL, which is the anterior cruciate ligament, which is a ligament that's in your knee. It prevents your tibia from sliding forward on the femur. Well, he damaged it in a football game. The sports medicine doctors were out there, and the physical trainers were out there, and they were doing all these orthopedic tests to test his knee because he kept complaining, I got knee pain, I got knee pain. He passed all the tests, but if you look at this guy, his legs are about as big as my thigh. His leg is about as big as my trunk. He's big, thick, thick, thick. Very strong glutes too. He had so much muscle mass that it stabilized that joint, where he got negative results on all the tests to test for that. It wasn't until he went in for his MRI that they found that he had torn his ACL. And they're not nice when they do those tests. I mean, they're pretty aggressive, all right? Point being is his muscles and his tendons stabilized his joints incredibly well to the point where he was negative on his tests. Yes, sir.
So for like that type of injury, would something get surgery or would it go back naturally?
It depends. It really depends. For him, he had to have surgery. He had to go in, and I'm not sure if he got a cadaver ligament or not. I'm not sure if he did or not. That's usually pretty common where they'll give them a cadaver ligament, especially if they're pretty young.
Yeah, because my sister they took part of the patella. It's weird. I don't get how they do that.
It's amazing with the stuff they got going on now. All right, the last component here of the knee, or excuse me, of synovial joints are the bursa sacs. All right, bursa sacs, their main function is to decrease friction in that joint area because you're going to have ligaments rubbing around the joint, tendons rubbing around the joint, all right, skin that's in that vicinity. So anytime when you get movement, I mean, it's real simple, you guys. If you were to take your hands, put them together and start rubbing them back, all right, it doesn't have to be fast, it doesn't have to be slow. Your hands are going to start to heat up. Well, think what's going on in your joints when you're running, all right, in your hips, in your knees, and all the joints in your feet, okay? Ligaments, tendons, muscles, skin, all these soft tissues are rubbing by one another. They're going to eventually start to heat up. So we were fortunate enough to have these bursa here that help to decrease that friction. So we decrease damage that's going on to the joints there, okay? So in some of these situations, you'll see them directly connected to the actual joint cavity itself, or they'll be separate. So I'll show you a picture here of the knee, okay? So you'll see that we've got random bursa, all over the place, okay? So you've got some on the back side, some on the front, especially around the patella ligament right here, or the quadriceps femoris tendon, okay? But point being is, they're in an area where there's a lot of motion and movement and friction being generated, all right? So these bursa help to decrease that, okay? All right, let's jump into classification of the synovial joints here, all right? Because now what we're going to do is we're going to get into how some of these synovial joints are structurally configured and what type of movement is going to occur at these joints. Okay, so I'm going to start off by being very, very general, and then we'll start to get specific. All right, but here's the thing. All right, I made this point before last class, and I started mentioning it in the beginning of this class. All right, when we classify these synovial joints, all right, they're classified by the movements that they're allowed to make due to shapes, all right, and of the joint surfaces. All right, that might not make sense yet, but when we get into the more details, I'll explain to you why. All right, how much movement or how little movement occurs at these joints is based on the anatomy, the structural configuration of these joints, okay? So the first one here, the uniaxial joint, all right, we're going to have one bone move in either one plane or one axis. All right, you've got the X, remember this, the X axis, the Y axis, this is from math. And then, of course, oops, E. All right, you guys remember that from math? All right, I can barely remember it. Point being is, all right, these are the three planes, all right, that we're going to be dealing with. So uniaxial joint will only revolve around one of these axes or that plane in which it resides in. You can figure out what biaxial means, all right? That's going to be two planes or two axes. Multi-axial, these guys move all over the place, all right? So you'll see that like your shoulder joint. We're going to go in through some of the details here, all right? But I just kind of want you to understand. You've got one axis, two axes, and three axes, okay? All right. One of the things that you want to notice on this page here, as we move down our page, we are going to start to increase our mobility, okay? And as we go down the page, we are going to decrease our stability. Because remember, there's a relationship between mobility, and stability. Remember that inverse relationship I said? Stability, okay? So as you increase mobility in a joint, you decrease its stability, okay? Perfect example, glenohumeral joint, your shoulder joint, one of the most mobile joints in your body, but it's not very stable, okay? It can be easily dislocated, all right? But a suture joint, all right, is incredibly stable, but guess what? Not a lot of mobility there, okay? All right, so let's jump in right away to our first type of joint, okay? The plane joint, all right? This is basically the articular surfaces that we're going to be dealing with are both flat, okay? So these will either not move at all, or I'm saying they have the slightest little, the most tiny amount of movement going on, okay? So these type of joints will have a side-to-side gliding or forward and backwards gliding, okay? And I'll show you an example of that. Something like we'll see in our carpal bones, the wrist, okay? Or all those tarsal bones that you see in the foot, okay? Those are plane joints. They just slide, those bones will slide by one another, okay? A hinge joint, can anyone guess what a hinge joint in their body? Elbow, yeah. Elbow, knee. Knee has a little bit more, all right? But basically what we're going to see is, just think of a door, all right? Like that one over in the room. Hinge joint, elbow, all right? You're going to have one surface that's going to be convex, all right? For example, the convex surface for our elbow joint is going to be the trochlear notch on the olecranon. And then the concave, all right, oh, just flip that. The convex surface will be the trochlea, and the concave depression is going to be the trochlear notch on the ulna, okay? Pivot joint, all right, this we see here in C1 and C2. Remember how the atlas and the axis, you had the odontoid process here, or the dens on the atlas, axis, and then the atlas just hovered around it, and it had a ligament that went around the backside. And this actual configuration, this pivot joint configuration, allows you to shake your head no from back and forth here, okay? So you're going to see rotation along, this would be the y-axis here, okay, the up and down axis of the dens. All right, condylar joint. All right, this type of joint, again, it's going to be similar to what we saw with the hinge joint, all right, but now we're going to see more of an oval configuration, all right, so we'll still have a convex surface there along with the concave surface, but in this case, because of the way those are configured, it can actually move in two planes. Like with the elbow, all right, that hinge joint was uniaxial, it would go flexion and extension, you know, straighten your arm, bend your arm. Okay, but when we're talking about a condylar joint, it can more than just flexion and extension. All right, we add another configuration to that. We'll talk about more of the condylar joint in a moment. Saddle joint, very similar to the thumb. All right, again, it's biaxial, so it's going to go through two planes. Right, but it's going to look, and I wish I could draw better, but you're going to have one structure, okay, that's going to have like this saddle configuration on it, and then you'll have another one come down. That's a bad drawing. Well, I'll show you. So hopefully, I've had time. I can show you a better picture than that. And then finally, one of my favorites, the ball and socket. Okay, that's what we saw in the femoral acetabular joint. Right, when the femur inserts into the acetabulum on the os coxa. Also, ball and socket joint is going to be your shoulder joint, the glenohumeral joint. All right, that's going to be multi-axial. It's going to be a move. It can do flexion, extension, rotation, lateral flexion. It has all these different planes that it can move into, all right? So it is the most freely movable joint in the body, okay, the ball and sockets. All right, so when we're talking about the two types of motion, all right, the gliding motion I mentioned before, you have two surfaces that are going to slide either back and forth or side to side. Okay, so you're very limited in this. Again, this is what we're going to see in our tarsals and in our carpals. But the movement motion that we're going to spend much more time on is the angular motion. Right? Angular motion, this is where we're going to see all those different types of movement that you've been hearing people talk about, like when you flex your elbow, or if you extend your elbow, or if you rotate your head, okay? So in this type of situation, when we're dealing with angular motion, okay, this is important. I've seen this asked as a test question on numerous tests, all right? When we're going to deal with the angle between two bones. So with angular motion, we're going to either increase that angle or decrease that angle between the two bones. So you need to know that definition, because I've seen it, like I said, asked on test questions before. All right, so we're going to run through each of these different types of angular motion movements here. Okay, so let's start off with flexion. All right, so when we're dealing with flexion, okay, we're going to deal with the anterior and posterior plane. So you're going to be moving through that plane, okay? So when you're flexing something, okay, think about when you flex your elbow. What are you doing with your forearm? You're bringing it closer to your humerus, okay? So you're going to bring the bones closer together, flexion. When you flex your knee, when you bend your knee, you're bringing your calf closer to your hamstrings, or your tibia and fibula closer to your femur. That's flexion, okay? The example here, bending the finger, same thing, okay? You're going to approximate the phalanges or approximate a phalange against the metacarpal, okay? So keep that in mind. You're always going to bring the bones closer together. Extension, same plane, anterior, posterior plane, right? But now you're going to move in the opposite direction of flexion, all right? So you're going to increase the angle between the articulating bones, right? So now you've bent your knee. Now you're going to go and straighten your knee. So when you straighten your knee, you're moving your tibia and fibula away from the femur. Same thing. I've just bent my elbow. I flexed my elbow. Now I'm going to straighten it out. I move my radius and ulna away from the humerus. That's extension. All right. So keep that in mind. We're going to increase the angle between the articulating bones. Okay. All right. Hyperextension. So this is anytime you guys have heard the term probably used in the slang vernaculum. All right, like, oh, I hyperextended my knee. I was playing basketball, or I hyperextended my elbow. All right, but that's a different type of hyperextension. That's injury-related hyperextension. All right, but when we're talking about for anatomy, all right, when you hyperextend something, you go past 180 degrees. Now for your elbow, some people can't. I can't get to 180 degrees, but I know that some folks are much more flexible, all right, and my daughter can do it. She can extend her elbow past 180 degrees, about 185 degrees, possibly even 190. So you have to go more than 180 degrees. You can too? Yeah. See, some people can. They're just more flexible than that, and they have, their joints are just a little bit, like your knee, the same thing. Like, same in the knee. Yep, and that's the thing. And and some people, you notice if you ask them to stand up straight and then tell them to lock out their knees, they'll go past that locked out position. And again, that's hyperextension of the knees. And it's just, in some people's cases, their ligaments aren't as tight. The example here is just looking up towards the ceiling, and that's in your book here. I'll show you a picture here in a second. But so this is, you'll see the person just looking as far back up towards the ceiling as they can. Lateral flexion, all right? In this situation, you need to know the plane. We're dealing with the coronal plane. And so understand, remember the coronal plane divides you into front and back portions, okay? So that means when you're doing lateral flexion, you're moving through that plane, okay? So for example, if I were to ask you to take your right ear and touch your right shoulder, you lean your head to the right, that's right lateral flexion. Okay, see, coronal plane cuts me front. So if I'm moving, I'll move through the plane this way. So if I say, hey, take your left ear and touch your left shoulder, I'm doing left lateral flexion. All right, I'm moving through the plane. Okay, so we'll see this, all right, mainly in the spine. Okay, and the more mobile portions of the spine, all right, in the cervical region, the lumbar region. You don't really have much lateral flexion in the thoracic region because your ribs are in the way. They prevent you from having much lateral flexion there. But in the cervical and lumbar region, we'll see that, all right, as the vertebrae move past each other. Let me show you some pictures here, okay? So here's the first one here, okay? It's showing you as the guy's looking down towards the floor, all right, he's flexing, he's approximating his cervical vertebral spine closer to the sternum, okay? And then when he returns back to the, I guess you would call it the neutral position where he's looking straight ahead, now he's increasing that angle into an extension. And when he looks all the way back towards the ceiling, same thing, he's hyperextending, all right, the cervical spine past 180 degrees, okay? Elbow flexion here, you can see you're approximating the radius and the ulnar closer to the humerus. And then when you start to straighten your arm back out, you are now increasing that angle, all right, of the radius and the ulnar with the humerus as you straighten it out. All right, here's some examples for the hand. I'm not going to go through everything. All right, when you bend your knee, that's flexion. When you straighten your leg out, that's extension. And now you can see this lady going through the lateral flexion phase. Yes, ma'am. Well, yeah, I know. Yeah, it's frustrating because when you're in the anatomical position, you're supposed to be neutral, you know. So in comparison, when you're looking straight ahead, it really depends. And this is the part that is frustrating to me. All right, when you go into extension, if you're in the anatomical position, technically you haven't moved. You're in that position. So if you were to go and bend your head forward, all right, and then when you move it back to that neutral position, that's the extension. And so it's going to be the excuse me, yes, it'll be the movement. All right, a couple other types of angular motion movements that you need to become familiar with: abduction and adduction. Easy way to remember these two types of angular motion is when you abduct somebody, all right, you take them away from somewhere. All right, so you always hear about people getting abducted. Well, they're being kidnapped and captured and moved away. Well, when you abduct, all right, abduct, you're moving, all right, whatever it is, your arm or a leg, you're going to make a lateral movement away from the midline or the axial skeleton. Okay, you're going to move away from your midline. Okay, so think of your axial skeleton, your skull, your vertebral column. All right, that's your midline. So if I move my arm out to the side like this, that is AB, abduction. I'm moving it away from my midline. When I bring it back down against my side, that's adduction. And think of it like this: you're adding it to your body. Okay? So now you're getting medial movement toward the midline. Okay? So to review, abduction is when I move my arm away from my midline. Okay? And then adduction is when I bring my arm back down medially back towards my midline. Okay? So you can see all these different examples. All right, we got our nice lady here. She's doing abduction, lifting her arm up. When she brings it back down to her side, that's the adduction. Now, when we're talking about abduction and adduction for your hand, okay, same for the wrist, I should say, excuse me. Okay, as we turn the wrist in, that's adduction. If we turn the wrist out, that's abduction. You guys see how it works with the leg? Okay, but this one I always found to be interesting, and finally with this edition of the book, they actually gave you a point of reference. For the fingers, the midline is actually your third finger. Okay, it's not the midline of your body. Okay, so when you open your fingers up, all right, when you spread your fingers out, that is abduction because they're moving away from your third finger. And then when you close all your fingers and bring them together, all right, you're bringing them back towards the third finger. That's adduction. That's the only exception, okay, that we're going to go over. And then one of my favorites, circumduction, okay? So remember in gym class when you were younger and the coach said, or the PE teacher said, all right, arm circles, everybody, all right? You started swinging your arms around, all right? That was circumduction, okay? So if you think about it, the closer you are to the axial skeleton, if we're dealing with the glenohumeral joint, that area is going to be moving very little. The more distal area, the hand, is going to be moving much more than the actual proximal region there, okay? So think about whatever movement that you'll be doing with circumduction, it's going to have this cone-like configuration, okay? You guys good so far? All right. You get these basic, and it's really important that you kind of know these terms, these directional terms, because when we do muscles, I'm going to say this muscle is a hip adductor. This muscle is a hip medial rotator. And I kind of expect you to know that. Okay. I'll show you too. But that's later on. All right. Rotational motion. We talked about gliding motion. We've talked about angular motion. Now we're going to talk about rotational motion, okay? And when we're talking about rotational motion, we need to deal with an axis. But in this case, we're going to deal with a longitudinal axis, okay? So we've seen pronation and supination. We're already familiar with that one, the two on the bottom there, all right? But what about lateral rotation and medial rotation, okay? So what I tell folks to do, all right, when we're talking about lateral rotation, all right, the definition says turns anterior surface of the bone laterally, all right? Well, what the heck, you know? I mean, it's hard to imagine. So the best way I tell folks is I said, bring your elbows at 90 degrees. You can make fists with your hands, okay? So if I swing, I've got to make sure that everybody at home can see me. All right, so I'm at 90 degrees, okay? So I'll face. So now if I want to do lateral rotation, if I swing my fist and arm out to the side, that's lateral rotation, right? When I bring it back across my body, that's medial rotation, okay? For the foot, for lateral rotation, it's real simple. Keep your legs straight. If you turn your foot out, that's lateral rotation. If you turn your foot in, that's medial rotation. Okay, so the anterior surface for the leg would be your thigh. Okay, so when you turn your foot out, that anterior surface, that thigh, turns laterally. When you turn your foot in, that anterior surface turns medially. Same thing when we're doing the arm, okay? The actual biceps, or the anterior part of your humerus, when I turn my fist out, when I swing it out, all right, my bicep is now facing lateral. When I bring it across my body, it's now going medial. All right, so that's going to be lateral rotation and medial rotation. Okay, so that's what we refer to the anterior surface. When you first read that, you're like, what the heck are they talking about? All right, always helps to have an example. Pronation, supination, we talked about that when we were going over the anatomy of the humerus and the radius, excuse me, the radius and the ulna. All right, so when you're in the anatomical position, your palms are facing forward. Okay, so you're in that supinated position. So again, I always thought of soup. I'm drinking soup with my hands. All right, when you turn the palms down, so when you actually turn your palms back, okay, that is going to be the pronation. And that's when you're going to get that lateral rotation, or excuse me, that medial rotation with your forearm, because your radius is going to swing over on top. So we're going to get that medial rotation of the forearm. Okay, so keep that in mind. When you're in pronation, your hand is going to be facing posterior. When you're in the anatomical position, your hand is anterior. Okay, quick sip. All right, rotational movements. Here you can see that lady looking back and forth here, all right, moving her head from side to side. So if you ask her to do right rotation, she'll look over to the right side. If you ask her to do left rotation, she'll look over to the left side. Those are going to be your rotational movements. So when we're talking about some of our extremities, our lateral rotation, here's the anterior surface, is now going to be facing laterally. The medial rotation, the anterior surface is now facing medially. Okay, same thing here with our feet, and then pronation, supination. You guys good with that? Not too bad. I know it's a lot to take in, but once you go over, the pictures help as best as they can. You know. Okay. So now we're going to get into some of the special movements. We're almost done. This is all, I love this stuff, but at the same time, it can be a little bit dry. All right. But it's, we're almost done, but we're going to jump into the special movements here. The special movements are movements that you won't see all that commonly, but we're still going to discuss them. Okay. All right. So depression and elevation, so much better than bones. Yeah, I know. All right, wait till you get the muscles. You'll be hating me. Okay, so when we talk about depression and elevation, okay, a couple areas apply to this. The mandible, okay, your shoulder blades, the scapula there. All right, so when we're talking about depression, we're going to move, let's, for the example, our jaw. All right, when you depress the jaw, you let it hang down. You're opening your mouth, okay? The mandible moves inferior. When you elevate your jaw, you're closing your mouth, okay? You're just like an elevator. It goes up. Your jaw moves up, all right? When we're talking about our shoulders, the scapula, if you shrug your shoulders up, okay, that's elevation. When you drop your shoulders down, that's depression, okay? So that's what this next part will show you. Okay, you can see this guy, when he's shrugging his shoulders, he's elevating the scapula. Okay, when he's depressing the shoulders, dropping them down, or when he's pressing, relaxing the shoulders, he's depressing the shoulders and the scapula drop down. All right, this one here has a tendency that people aren't quite as familiar with dorsiflexion and plantar flexion. All right, this has to do with the ankle joint. Okay, so if you're going to, I just got done watching. I thought it was a really good documentary on Michael Jordan and the Chicago Bulls. This is during my younger years, back in the 80s and 90s. But anyways, so I feel like I can play basketball with the best of them. But my point being is, referencing that, when you go to do a slam dunk or a layup, all right, when you jump off with that one foot, all right, when the balls of your feet, all right, press on the floor, and then you just start to jump up, all right, and you're pointing your toes downwards, that's plantar flexion, okay? Plantar flexion, right? The example here is a ballerina on their tiptoes. I always thought of plantar flexion when you just go up for a layup for basketball. All right, or if you go on your tippy toes, all right, that's plantar flexion. The other one, dorsiflexion, okay, is when you're actually, they say digging in your heels, I say pointing your toes up to the ceiling, okay, when you just bend your ankle and point your toes up towards the ceiling. All right, that's dorsiflexion and plantar flexion. Eversion and inversion, it's a little bit easier, okay? The one here, this is the most common type of ankle sprain, by the way. An inversion ankle sprain. So if you ever when you hear someone say, oh, I rolled my ankle, 90% of the time they roll it this way, right? But inversion is when you're pointing the sole of your foot inwards, okay? Right? Eversion is when you're turning the bottom of your foot out away, all right, from your body. This one is actually a tougher maneuver to do. All right? So inversion is turning it inwards, okay? So the sole is facing medially. All right, eversion, the sole is turned out. All right, it's going to face laterally. Kind of bummed this edition here, they've changed the model for these pictures. The other guy that they had on here used to make goofy faces. It's all good. All right, protraction, retraction. Again, dealing with the jaw, okay? So if you are asking somebody to protract their chin, all right, they are going to press it forward, sliding the mandible forward from posterior to anterior. All right, retraction, you're asking them to pull their jaw inwards, so they're going to be pulling it from the anterior position more towards the posterior position. Very common when we're dealing with TMJ. All right, those maneuvers are quite uncomfortable for that person. Speaking of TMJ, how about the temporomandibular joint? Let's talk about that for a moment. All right, a couple things that you should know about the temporomandibular joint. All right, one, it is the only what we consider to be mobile joint in the skull. Okay, most of those other joints that we've talked about, all all right, are sutural joints. There's not a lot of motion there. But what I really appreciate about this joint is not only does it have an articular capsule, right, it has its own little disc. And we don't really talk about it that much, right? When I was telling you all the places that you find fibrocartilage and whatnot, right? It's just that it's not exciting enough to mention that, all right? But you have, in your temporomandibular joint, you have a disc there, right? The important aspect of that, yes, it's made of fibrocartilage, but it'll divide that synovial cavity into two chambers. I've seen that asked on a test before, all right? Let me take a quick sip here. Right, two chambers. So we have two ligaments here that are worth mentioning for the temporomandibular joint. Okay, the sphenomandibular ligament. And again, if you dissect these words here, sphenoid, all right, you can figure, all right, that's got to come from the sphenoid bone. Okay, then obviously we know where the mandibular bone is. So this is going to go from the sphenoid to the mandible. All right, so when it goes anterior and inferior, all right, it's going to help to prevent, all right, that type of excessive movement. All right. The other one is the temporomandibular ligament, so you can figure out where that comes from. All right. And this one, again, is also going to be inferior, but it also goes posterior. So it's going to help to resist those movements there. Helps to resist dislocations in those two directions, both inferior and posterior, okay? So the main movement that we see at the TMJ joint is going to be hinge. All right, you're going to have some gliding, all right, especially when you're grinding food from side to side, like a cow chewing its cud. That's the main purpose of your molars, is to crush and grind food. But you don't think about it when you're doing it, but there is a slight amount of side-to-side movement going on. And you have two muscles, you don't need to know their names for this semester, all right, but they help with that side-to-side gliding movement there. Right? You'll also have some pivot motions there too. Okay. So the main one that we're affiliated with is going to be the hinge movement. All right. When we have that opening and the closing of the mouth there. Okay. All right. So let's take a quick picture or a peek here at the temporomandibular joint. All right. You can see here those two joints. Excuse me. Those two ligaments that I was telling you about. Okay. Temporomandibular ligament and then the sphenomandibular ligament. All right, and so they're going to be right around the front side here in the lateral portion of that joint, and they're going to help to prevent, all right, excessive movements in that area. So here, when we get really close in, all right, here's the mandibular fossa here, all right, and then you got your condylar process here, all right, and then right in between, you've got your articular disc here. It divides, all right, that capsule into two separate compartments there. I talked to a dentist about this. TMJ says he hates treating TMJ patients. To this date, TMJ disorders are a very difficult condition to treat, depending on what the cause is. Does anyone here know anybody that has TMJ? You know somebody? Yeah. I had it for a little while. I got punched in the jaw when I was in high school, and it messed my jaw up for a little while. Then I started getting it treated. It ranges from bite guards. In some cases, they can go in there and actually do surgery, all right, if they have to. Pardon? Did you find that the Invisalign helped? Because I've heard that. You hated the Invisalign? No, and the only reason why is because my wife, she had the Invisalign and she hated it. She would not. She's always that person that smiled, but she would never smile with the Invisalign on. Oh yeah, I'm telling you, I used to be officially never treated for TMJ, but I've had to. Yep, yeah, that teeth clenching can be an issue, especially at bruxism there, and usually a dental guard works out. But the Botox is something that I used to be against Botox, more so because of the fact that Botox, botulism toxin is one of the most potent paralytic toxins that bacteria actually generate. And so we decided that we were going to just start injecting it into our bodies. I'm like, well, that's always smart. But they have actually found people with really bad torticollis, they can inject Botox. And in fact, I had a patient that she had pretty bad torticollis. And when I first met her, literally her head was laying on her shoulder. This is how bad it was. It was bad. And so we did a lot of physical therapy treatment and whatnot. And we got her to about, we got her to about, well, it was like this, which was really good. But once she got that Botox injection, she was as normal as she could be. Maybe a slight tilt, but it's come a long way.
What did you do to get put to the thing?
I was at a party and I poured a beer on somebody. So I guess I deserved it. So anyways. I was bad boy. All right, let's talk about the shoulder joint, okay? When we're going to talk about the shoulder joint, there's a couple different joints that are going to be involved with the shoulder joint. All right, the first one is the sternoclavicular joint, okay? So we've seen the sternoclavicular joint because we saw the sternal end of the clavicle just sit right on top of the manubrium there, all right? So this type of joint is a saddle joint, and I'll show you a better picture here in a second, all right? We also do have an articular disc here, okay? I shouldn't say same. Similar situation to what we saw with TMJ, all right? This disc is going to divide that cavity into two synovial cavities here, all right? So again, when you think about it, all right, the motions that really occur here at this joint, all right, elevation and depression, that's pretty easy to think about because when you elevate your shoulders and depress your shoulders, you're going to get that. This is the one that's always blowing my mind, circumduction. All right, and I'm trying to imagine circumduction, but you have to understand when you're doing circumduction with your glenohumeral joint, all right, your clavicular, your clavicle has to articulate with the sternum there, and so there's going to be some motion and movement and some circumduction, mild as it may be, is still going to be present at the sternoclavicular joint there. Okay, so what holds this joint together is pretty much just the ligaments mainly, but also some of those are articular capsule fibers there, okay? So it's very difficult for this joint to be dislocated, go figure, all right? Because when you look at it here, you think that it just kind of sits there idly, all right, on top of the sternum, the clavicle is what I'm referring to, all right? But because you have all these ligaments and this capsule fibers here, and then below that area, all right, you've got the costoclavicular ligament. This ligament here I'll just keep drawing lines. This ligament here provides a huge amount of stability to this joint, all right, because it prevents it from being superiorly dislocated, okay? All right, so the next joint that's part of the shoulder, okay, is the acromioclavicular joint, all right? This joint's basic joint. Okay, you have two bones that are going to come together, all right, so it's going to form a plane joint here, okay? And again, we're dealing with another articular disc that's in that joint cavity there. And then again, we're also going to be playing or dealing with two ligaments that are going to be involved. So most commonly, all right, when this joint gets damaged, all right, you are going to see the clavicle, the clavicle is going to move superiorly. So on some people, you'll see a little bump on their shoulder, okay? And it can be dislocated mildly and whatnot, but usually when that occurs, you have damaged, all right, the acromioclavicular ligament. That's the most commonly one that gets damaged. All right, then everybody's favorite, the glenohumeral joint, shoulder joint. Okay, it's diarthrosis. It's the most mobile type of joint we have. Specifically, it's a ball and socket joint. So this is a multi-axial joint. Okay, so of course you need to know this fact. the most unstable and frequently dislocated joint in the body because it has the greatest range of motion. Okay? I'll be mad if nobody gets that on the test. That's an important concept. I've mentioned it several times. Problem with the glenohumeral joint, and you saw it when we were labeling, right, that the glenohumeral fossa is pretty shallow. Okay, so you got the head of the humerus here. Right, it's pretty shallow. So no problem. What has happened now is you have this fibrocartilaginous kind of ring that covers, all right, the end of the glenoid fossa. And what that does is it makes that joint a little bit deeper because it's a relatively shallow joint. So if you ever heard of somebody having a slap tear, okay, that's a tear of the glenoid labrum. It's a very common injury type of tear in somebody that plays basketball, plays baseball. They'll get a slap tear. And it's just a small tear. Well, I shouldn't say a small tear, it varies. But it's just when they put they tear, all right, that glenoid labrum, okay, and the flap of that fibrocartilage is just going back and forth, and it's causing all that pain there, okay? Tons of bursa, makes sense, right? Because there's a lot of motion and movement going on there, so we need to reduce that friction. So we're going to have many bursa located throughout that shoulder joint. All right. In addition to that, all right, we're going to have all these tendons and ligaments. Now the tendons are going to come, all right, mainly from the rotator cuff muscles. We'll talk about those in a second here. All right. A couple names here for the ligaments. All right, but an important structure that comes in close approximation to the glenohumeral joint is this guy right here, the long head of the biceps brachii. Okay. In a lot of cases, if people have some tenderness, all right, and the anterior portion of their glenohumeral joint, all right, and they said, you know, it doesn't really bother me too much when I'm sitting, but when I try to go and bring my arm forward, all right, it bothers me. Or if I go to flex my elbow, it bothers me. Well, the biceps brachii muscle is involved in shoulder flexion and elbow flexion. So an easy way, it's kind of a cruel way to do it, but an easy way to test that is you have them, it's called the empty beer can test, all right? You put the arm out at about 40 degrees, and you turn the thumb down, and you have that person hold that position, and you push down on that. And if it causes them a pretty significant pain, then the next part, what you do is you push right on that area there, and you ask them to raise their arm forward. And if that causes them pain, most likely they have a sprain strain of the biceps brachii muscle. It's just one of those things that goes right in front, and I'll show you, I think it's on this slide here. Before I jump to the next slide, though, I do want to talk about the rotator cuff muscles. All right, there's an acronym for that. I think I mentioned it before to you guys. SITS muscles. Did I say that in lab? Okay. So you want to know this. Well, you don't have to know the acronym. It just makes learning the muscles a little bit easier. We're going to learn all these muscles anyways when we do lab. Okay. But there's 4 muscles involved. All right. The subscapularis, which we talked about a little bit because that sits in the subscapular fossa on the anterior side of the scapula. All right. Then we go to the back side and we see the supraspinatus, and that sits in the supraspinous fossa. Infraspinatus sits in the infraspinous fossa, and then there's teres minor. Okay, so we're going to talk all about these. Anyways, these 4 muscles, all right, help to add stability to your glenohumeral joint. Remember, it's pretty shallow. So, okay, to help offset that shallowness, we added the glenoid labrum there. That helps a little bit, but now we need something to add a little bit of stability. Remember, we were talking about what do tendons do? One of the things that they do is they add stability to a joint. Well, these 4 muscles are specific for that. They're going to add that joint stability to an already unstable joint because it's so mobile. Okay? So what a lot of folks don't realize, all right, is that you'll have these tendons, all right, that come off of these muscles that will literally fuse with the articular capsule. See it all the time, and we haven't learned this structure. It's called the IT band. All right, you guys have ever heard the IT band, that band that runs on the side of your leg? All right, it stands for iliotibial band. Well, that fuses with the knee capsule, okay? And folks will complain of knee pain all the time, and they could be an avid runner, but if they're having problems with one of the muscles in their hips, it's called the tensor fasciae lata muscle, which attaches onto the IT band. I'll talk about this more when we do lower extremities, all right? They will get knee pain. Same thing here, okay? People will complain of glenohumeral shoulder joint pain, and it could be one of their actual rotator cuff muscles, because that tendon inserts and fuses into the articular capsule, and it can be causing issues with the shoulder joint. All right, so here's that picture here that I wanted to show you. Oh, bummer. Oh, there it is. Okay, phew. All right, so if you look here, a couple different things. Here's the acromioclavicular joint, and you can see all these different ligaments. You can see all these different ligaments that play a role in the stability of the acromioclavicular joint. These two ligaments here, the corticoclavicular ligament, all right, and then also the coracoacromial ligament, they get damaged, then it's easy for the clavicle to dislocate superiorly. So it'll move up like a springboard. So then it'll start to sit higher. And that person will have like this drop off on their shoulder. It's really quite easy to see. All right, but if we move over here, all right, well, we can't. Here's the glenoid labrum here. It's tough to see, okay, but it makes it a little bit deeper. All right, if this was just bones, you wouldn't have this structure here. So there's the glenoid labrum, all right, and that adds a little bit of depth here to our ball and socket joint. But also, what helps to add to the stability there is when we now add, all right, this is the tendon here of the supraspinatus. So supraspinatus sits up here, okay, and then subscapularis sits down here. Anyways, point being is all these muscles will attach onto, all right, the humerus here and hold it close into the joint so it doesn't become dislocated here. And this is that tendon here I was telling you about, the tendon of the biceps, the long head of the biceps brachii. So when you press right here, okay, right in the front of their shoulder, okay, right over that joint area there, if it's inflamed, it'll light them up. They will not be happy with you. All right. So here, just to kind of give you, I might as well, here you can see what we're talking about for the glenohumeral joint, for that flexion there. All right. So when you're bringing your arm forward, okay, that's going to be flexion. When you're bringing it back, that's going to be extension, okay, for the whole shoulder here. All right. This view here, we can see, all right, we have several bursa here, all right, again, more of the ligaments, and then some of our rotator cuff muscles in and around that are going to add stability to this joint. Because again, we're not going to have a whole heck of a lot of depth into that glenoid cavity there. All right, shoulder dislocations. Has anyone here ever met somebody? You've dislocated your shoulder? Really? Which one, right or left? What were you doing, if you don't mind me asking?
I fell.
Oh, you
And
fell.
when I fell back on, it popped out. It actually popped out right back in.
It did go back in? Okay, all right. I had a patient, she's had her shoulder dislocate 3 or 4 different times, doing various things. Now, after you do it the first time, unfortunately, you're more prone to having it happen again because you've kind of stretched out some of those tendons and ligaments and whatnot. And depending on how bad it is, you could have some tearing of some of the soft tissues. You have, wait, what did you say?
They said I had a crack in one of the surrounding bones.
Oh, really?
Yeah.
Okay, but yours went right back in though. So in some cases, if it's out and it stays out, where you have to have somebody put it back in, has anyone ever had to put a shoulder back in? It's not pretty. I watched an episode of ER and the one guy stuck his foot in the other person's armpit. and pushed it in. I wouldn't do that. Yeah.
Like he would be like, we'd be going down the road, and I don't know if it just what happened, but
Yeah.
he would pop out, and he would we'd pull over, he'd get out, and he'd be like, okay, I'm good, and we're like,
The doctor
What
at
just
work
happened?
could do that. He'd pop it out, pop it back in.
Oh, see, yeah.
What just happened?
Unless you're Mel Gibson from Lethal Weapon, you can dislocate your own shoulder and then go kill 10 guys and then put it back in. So a couple of things when we're talking about a shoulder dislocation, okay? Remember, we just went over 3 different joints that are part of the shoulder, all right? So it depends on which one we're talking about, all right? When we talk about a shoulder dislocation, usually we're talking about the glenohumeral joint, all right? When we talk about a separation, like, oh, I got a separated shoulder, most of the times we're referring to the acromioclavicular joint, okay? And so, like I said, when that occurs, all right, you're going to see almost like a drop-off kind of configuration there, all right, on the person's shoulder. And so, I would much rather separate my acromioclavicular joint than actually dislocate my glenohumeral joint, all right? But we're going to see, all right, in a glenohumeral joint dislocation, abduction plays a huge role, all right? And you have a joint capsule that goes around your glenohumeral joint, okay? So anytime, and you want to, for those of you that have ever sprained an ankle, same type of situation. They call it plastic deformity. It has nothing to do with the material plastic, but once you've damaged specifically ligaments, because they're made of that dense regular connective tissue, when you damage that ligament, like in an ankle sprain, okay, you've stretched it out a little bit. So it won't be its original shape. So you're more prone to re-injuring that ankle. Same concept applies here to the glenohumeral joint. All right, when you've stressed, all right, that joint capsule there, now you've made yourself more prone. Physical therapy helps, and a lot of times when they do physical therapy and surgery, obviously, depending on how bad the damage is, but physical therapy, what they do is they strengthen the rotator cuff muscles to add to that stability to prevent that from happening. All right, elbow joint. This one here, again, is a hinge joint. Okay, so there's actually 2 joints in your elbow, all right, because you have 2 bones in the forearm, and then one with the humerus. You've got your humeral ulnar joint, and then your humeral radial joint, okay? So when we saw, all right, the articulations between the trochlea and the ulna, that was more of the hinge. The humeral radial joint, that's a little bit different, all right? It'll act also as a hinge, but, okay, the radius, here's your capitulum, it's like a ball-like structure. The head of the radius has a little bit of a depression on it, and the ball of the capitulum sits in there. So the radius kind of swivels, all right? It swivels on that ball. That's why you're able to get that supination and pronation, because the radius, when it turns over, it swivels on top of that capitulum there, okay? So if you can see, well, this picture doesn't show it exactly the way I want it to. Well, the lateral one does. Nope, it doesn't. Anyways, I didn't get to, well, yeah. Anyways, the 2 motions that we're going to see here for the elbow joint is going to be flexion. Remember, it's an angular motion, so we're going to approximate or decrease the angle between the bones. And then extension is going to increase the angle. So when you straighten your arm, all right, that's the movement that you're going to see. And then this one here is for the supination, pronation. Show that. Boo. Boo. All right. Let's jump into the hip. All right. Real quick here on the hip. All right. This again is another ball and socket joint. Okay. Because the head of the femur is going to insert, all right, into the acetabulum. All right. Except this scenario, we're not going to have as much movement like the glenohumeral joint because our ball and socket joint is a little bit deeper here, but the joint capsule is much stronger, okay? And because it's much stronger, it's more stable, so therefore we're going to have less mobility, all right, in that region compared to, okay, the actual glenohumeral joint, all right? Similar type of situation in which we saw in the glenoid labrum, we also have our acetabular labrum, all right? So that's that ring that's going to go around the edge of the acetabulum, so it deepens the ball and socket joint there, less likelihood of having a dislocation, increases stability in that region there. So when we look here on our hip joint here, you can see all these ligaments here are all part of that joint capsule, right? And there's tons on the front, on the back, all right? All these ligaments are contributing to the strength of that joint, but unfortunately, they're reducing the amount of movement. Now, when we talk about hip flexion, okay, this is like kicking a ball forward, all right? You're going to bring your knee up towards your chest. That's the flexion component of it. When you're bringing your leg back, all right, like when you're swinging your leg back, if you're stretching, that's the extension component, okay? Abduction, we're going to move our leg away from our midline. We bring it right back down to the middle. That's our adduction. Yes, sir.
So, like, do you have like a fracture, like a compound fracture, you know, like punctures the skin? Or that, does that like mess up the ligament too, like the?
Oh, absolutely. It can sever the ligament. It can, you know, damage the ligament.
So, like, you get like a fracture, like the clavicle, and then it really was about a fracture, but it messed up like one of the ligaments there. Did that like cause you to feel pain where the fracture was, even though it wasn't in your?
Wow.
Like it actually didn't have anything to do with your shoulder.
There's some people that have fractured their clavicle that don't have any correction done to it. So they'll just see the clavicle. Because if that ligament gets damaged, right, that clavicle literally like a springboard just pops up, and so it stays there. And if it doesn't bother them,
Yeah, I
they
have
don't
it
care.
here, but it's not something that's like popped out.
Did it? Yeah. I mean, now that could be. Did you fracture it, or was it? You think you just may have damaged the ligament?
Basketball, someone hit me, someone threw my shoulder behind me.
Okay. Yeah. Well, most likely it's not fractured, but they probably damaged that ligament if it's more pronounced on that side. It's not uncommon. Yeah. All right. I'm going to skip over that and jump right to the knee joint here. Just try to finish up real quick here. All right. Here's our knee joint. Again, pretty much it is a hinged joint, but there is a slight amount of rotation. All right, a little bit of internal and external rotation, all right, that you will see. But for the most part, we classify it as a hinged joint. All right, again, there's a muscle, you don't need to know its name for this course. It's called popliteus, and it locks the knee joint into place, all right, when you're going into extension. So we don't have that slight rotation. But when the knee is flexed, we'll get some of that rotation occurring, okay? So again, like what we saw on the elbow, right? In the knee joint, we have two separate articulations because we have two separate bones in the leg, okay? You got your tibia, and then you also will have your fibula, but now we're going to add in the patella, okay? The patella plays a role here, all right, because it actually forms a joint because it is a bone and it's an articulation, okay? So you get the tibial femoral joint, and that's pretty much your knee joint proper, all right? And then you have the patella on the front side there, all right? That's going to also create its own joint, okay? But the main purpose of the patella, there is some functionality for protection of the knee joint, but also it helps to allow the ligaments or the tendon of the quadriceps to move with much more ease across the front of the knee joint there. All right, so here you can see, all right, some pictures from the anterior component with all the muscles involved. And you can see, again, we have quite a bit of ligaments, all right, that are holding this joint together, and not to mention the actual articular, the actual capsule itself here, all right? And then we look on the back side here, again, same thing. we're looking at tons of ligaments. Not only that, we have several muscles that are going to contribute to the stability of this joint. When we get into the internal portion, this is where we see the posterior cruciate ligament and the anterior cruciate ligament. This is a posterior view. So the predominant ligament that you're going to see is the posterior cruciate, and then you can see just a little bit of the anterior cruciate ligament. And then you've got ligaments on the inside of the knee and on the outside of the knee. You've got the medial collateral ligament, and then you got your lateral collateral ligament. They keep the knee from shifting from side to side. Now, the anterior view, when we bend the knee, all right, the more predominant ligament is going to be the anterior cruciate ligament. These are the ones that are the anterior cruciate ligament is commonly injured more so than the posterior cruciate. And then the medial collateral ligament is also more commonly injured compared to the lateral collateral ligament. All right. Again, one of the things you do want to keep in mind is the patellar ligament versus the quadriceps femoris ligament. The patellar ligament is going to be that ligament that extends from the patella to the tibial tuberosity. Okay. Granted, the patella is part of the quadriceps femoris. It's a sesamoid bone. The sesamoid bone resides inside of a tendon, right? The body's largest sesamoid bone. But when we're talking about from the patella, okay, down to the tibial tuberosity, okay, that portion is called the patellar ligament. Okay, well, I'm going to stop there. And any questions? I know there was a lot. A lot.
I wish you were on the demo.